Hello, Reworld clinicians. This is Ali Nasseh with a special presentation for you. I have the pleasure of being joined today by Dr. Chafic Safi Dr. from Montreal, Canada. Dr. Safi is the newest member of our faculty here at Reworld Endo and is a graduate of the University of Pennsylvania postdoctoral endodontics program, where he currently is the adjunct assistant professor and lecturer. Is also a lecturer and assistant professor at the McGill University and is the founder and director of Centre Endodontique, which is his practice in Saint Laurent, where he holds a clinical practice and doing clinical cases. Dr. Safi, first and foremost, welcome aboard to Reworld Endo, and thank you so much for joining me today.
Thank you. It's my pleasure.
Now, I understand that you have a short presentation for us titled Revascularization of an Immature Tooth, a special case report with some follow-ups. Now, regeneration has been the rage over the past few years, and as we all know, that the best root canal is a vital pulp, obviously. So our goal is always, in order of priority, to first avoid root canal therapy if not possible, then try to regenerate the diseased tissue, and then lastly, do conventional root canal therapy if all of those other two options are not available. So I'm really looking forward to hear your presentation on this, and I think you start by this case that you're going to share with us. So I'll just give you the podium here to go forward and present your case.
Perfect. Thank you. So yeah, as you said, you know, the revitalization or revascularization in a case, in an endodontic case, is where we want to try to encourage or promote the natural tissue to repopulate or reproliferate in the necrotic pulp space. So in this case here, we have this lower second premolar that presents to the clinic. And what we see here, for example, is we have the challenges, which is on the biological side, we have very deep caries, as we see coronally, and this has caused the microbial invasion of the root canal system and caused the development of apical periodontitis. In this case, it might be overlapping with the development of the tooth, but clinically, you know, that patient was symptomatic to percussion, and so this signifies that there's some kind of apical periodontitis happening in this tooth. Technically, when you want to save this tooth, when we look at this X-ray, although it's a 2D X-ray, we can have a lot of information. First, we have this very wide canal, and then we have also an open apex. So this makes it a very tough and challenging to be able to do a root canal, or even sometimes to try to save that tooth. And so, as we spoke during revitalization, our biological goal is we need to lay out the grounds for the natural tissue to grow into the pulp canal, and so that is why we have to first disinfect the root canal system to be able to promote the natural root maturation. And obviously, technically, what we need to do is to save that tooth. So what we need to do to accomplish our goals is we need to have an armamentarium. The first one is a biological armamentarium that the patient has in his own, let's say, natural tissues. First, we need the stem cells, which are present in the, most of the time, in the periradicular areas, and we need growth factors, and we're going to look into where these growth factors are going to come from. Clinically, what we have to have in our armamentarium as endodontists or as general practitioners trying to do regenerative endodontics is need to have a good standard irrigation protocol. We need to use a good intracanal medication, an orifice sealer, and a scaffold. And we will look in a couple of slides where each of these items will come into play when doing a revascularization case. So in terms of stem cells, you know, we have a lot of stem cells in the root canal system, or in the area of the tooth. We have, for example, the pulp stem cells. We have the stem cells coming from the primary teeth. But most of the time when we do revascularization, we rely on the stem cells coming from the apical papilla. And in this case, as we see in this clinical picture, it's a picture of an extracted tooth. And when this tooth was extracted, the dental sac came with it, the dental sac, which promotes really the development and the growth of that tooth and the maturation. And attached to the roots was the apical papilla, which contains stem cells that will promote, especially in this case, the development of pulpal tissue. And now, in terms of growth factors, when we have this ingrowth of tissue into the pulp canal space, we need this growth factor to be able to induce and to promote the maturation and the proliferation of this tissue. Now, during the normal development of a tooth, we have these normal growth factors that are hidden inside the dentinal tubuli. And there's a natural biochemical cascade that happens naturally when there's no insult to the tooth, such as caries or trauma. So when the growth of a tooth is halted, such as in this case by caries, all these growth factors are imprisoned into dentinal tubuli, and we will have to try to release them into the pulp canal space to be able to achieve our ultimate goal, which is the ingrowth and the proliferation of natural tissue inside the pulp canal space. So having spoken about the armamentarium, the biological armamentarium, our armamentarium first, as I said, will rely on irrigation. And we need to use a couple of irrigants or irrigation agents that will have specific properties, such as bactericidal, because we want to reduce the microbial load inside the pulp canal space. We need also this irrigant to be non-toxic to stem cells. We don't want to have the stem cells and all the pulp and all the tissue come into the pulp canal space, and then once we irrigate, then to that irrigant to kill them or to get rid of them. So we need something to be very biocompatible, if you want to use this word. And we also want the irrigation to be able to promote the release of the growth factor that are stuck inside the dentinal tubuli. And looking at all the irrigants that we have today in the endodontic world, research has shown over and over that the best irrigating agent that is bactericidal and non-toxic to stem cells is sodium hypochlorite at a concentration of 1.5%. Everything more than this tends to become much more toxic to the stem cells, and everything less than 1.5% tends not to be as bactericidal as we wish it to be able to promote revascularization. And in terms of releasing the growth factor that are stuck inside the dentinal tubuli, research has shown that EDTA, which is a decalcifying or a chelating agent, tends to really decalcify slightly the walls of the root canal, and so to be able to promote the release of this growth factor inside the root canal, so that they can meet with the stem cells, and thus induce and encourage and promote their proliferation into the root canal space. We also spoke about our clinical armamentarium that we need to rely also on an intracanal medication. Unfortunately, even though the 1.5% sodium hypochlorite is a very good bactericidal agent, we need an extra chemical or an extra biological agent to help us achieve a good decrease in microbial load. In this case, we need to also be careful to not use something that's very concentrated or very toxic, because it will also tend to destroy these stem cells that are coming into the root canal system. So what we suggest, or what the literature out there suggests, is the usage of a triple antibiotic paste made of ciprofloxacin, metronidazole, and minocycline in a 1:1:1 ratio, or a 1:1:1 concentration. Everything more than that tends to be much more toxic to the stem cells, and so it will not be able to promote their proliferation inside the root canal system. The third item on our clinical armamentarium that we need is a good orifice sealer. As you will see in a couple of slides, once everything is done, once we have kind of promoted the ingrowth of the tissue into the root canal system, we need to really seal that system. And there's nothing better than the bioceramic family of material, which is, let's say, for example, the well-known MTA out there, or recently a lot of literature has been out there on the bioceramic root repair material that we see here in the slide. We need to make sure that whatever we use has an excellent sealing ability, which is in this case the same for MTA and bioceramic. We need to make sure that they promote the stem cell survival. This has been shown repeatedly for both material. And we need to make sure, especially if it's an anterior tooth, maybe in this case it's not important, that the material we use, since it's been put in the cervical area of the tooth, that it does not stain the tooth. I have not added it here in my presentation, but research is out there that MTA unfortunately does tend to stain the tooth, but when compared to the root repair material does not stain the tooth at all. So that's why it's better to use root repair material as orifice sealers in these cases. And finally, our last requirement, before we look at the clinical procedure and see how all these materials come into play, is the use of a scaffold. And the purpose of that is to support the ingrowth and to supply a framework for the growth of stem cells. Now, we could use a lot of, let's say, a cola tape or cola coat, but recently I heard about this Sinos putty, which is some kind of hydroxyapatite collagen material. And this is the picture that we see on the slide on the left-hand side. We could cut it into like small strips and insert it into the root canal system before closing everything. And this will promote the stem cell survival and supply a framework for the ingrowth and survivability of these stem cells. So first and foremost, before we start adventuring ourselves into these procedures, we need to make sure that we are selecting the good case to receive that kind of procedure. And a good case always starts with a good patient. We need to make sure that we have a compliant patient and or guardian, because this procedure will take usually more than one visit, usually 2 visits, sometimes 3, and we need to keep a long-term follow-up on this case to make sure that it's working. And in this case, that in the case that this procedure doesn't work, we need to make sure that the patient is able to come back to be able to offer him other treatments to be able to save his tooth. And also another requirement is that we need to make sure that the apical diameter of the tooth we are selecting to do a revascularization on it has a large apical diameter that's able to promote the ingrowth of the blood vessels and other tissue from the periapical area. This is very important because if we have a small diameter, which is, let's say, smaller than 1.5 millimeter, which is the minimum that we need, then the ingrowth is going to be very prohibited, and thus this will put into risk our procedure. So you could take, let's say, sometimes a file that's smaller than, let's say, like around 120. Make sure that it's very loose around the apical area, and if that's the case, then you're in the game. You have a very good case, taking into account that the patient is a compliant patient. So in terms of a clinical protocol, the American Association of Endodontists has published a lot of recommendations and guidelines, and it's divided into two appointments. The first appointment, of course, after the clinical exam and diagnosis, and after filling the informed consent, you need to make sure that the patient is very well anesthetized locally. After installation of rubber dam, caries is removed, and the access into the root canal system is made. The second point is that we need to estimate the working length of the tooth. However, we need to make sure that we don't file, or we don't, let's say, excessively file the root canal while doing this, because we don't want to remove much more dentin than the tooth has already left with after it has stopped its maturation. So usually I tend to take, let's say, a small file around, let's say, size 50 or 60, try to put it in there, hook my apex locator on it, and then I also confirm it with an X-ray. After the working line estimation, we do a gentle copious irrigation of 0.5% sodium hypochlorite. We dry the canals, we insert our intracanal medicament, our triple antibiotic placed using a lanceolus spiral. We put a small cotton pellet and temporary restoration, and then the patient is released, and we see him in a second appointment, which is usually about 10 days after the first appointment or 14 days. We need to make sure at the beginning of the second appointment that the signs and symptoms have disappeared. If there's still remaining signs and symptoms, we can either repeat the first protocol, meaning remove the temporary restoration, re-irrigate, reintroduce another cycle of antibiotic paste, or we could change totally our treatment plan. Let's say do some other kind of let's say apexification or whatever we have in our endodontic list of treatments for the patient for a case like this. In the cases where the signs and symptoms have disappeared, we proceed with the local anesthesia. However, in this time we have to be very careful. We need to use a vasoconstrictor-free anesthesia because we need to promote the ingrowth of the pulpal stem cells from the periradicular areas. And if we use an anesthesia with vasoconstrictor, those blood vessels that we will kind of create bleeding from them will be very constricted, and the bleeding creation will be very, very, very hard. Secondly, in the third point, we're going to irrigate with 17% EDTA to be able to release those growth factors that are stuck in the dentinal tubuli. We follow this by the irrigation of saline. Then we dry the canals. Following that, we're going to create the bleeding into the root canal system. We're going to insert, usually what I do is I bend a size of 40 stainless steel hand file. I insert it into the canal, let's say 3 millimeters from the cemento enamel junction further down. And then I see the bleeding under the microscope flowing up. Then I remove my file. I wait until I make sure that the bleeding is very stable. In other words, that it's not going to crumble down or disappear. When this is done, I place a 3 or 4 millimeter of the root repair material putty around the cervical area. Then after that, I place a glass ionomer followed by a permanent restoration. And so in this case, what has been done is the following. As we see on the left-hand side is a preoperative X-ray. On the right-hand side is a postoperative X-ray. I've used, in this case, root repair material to seal the orifice area, and I've followed the same protocol as I stated before. And the patient came back about, I remember well, 6 or 7 months after that, because he told me he was in pain. So then it was a 12-month follow-up, excuse me. So I took an X-ray, and what I can see on this X-ray is we see that the root canal system has grown in the mesodistal direction, meaning the root canal is thinner, so the walls have thickened. We also see that the apical part is becoming more and more constricted, taking the shape of a natural root that has matured. And we can also compare this second premolar to the first premolar, and we can see that they're following almost the same pattern of growth. And what's very important and that's very striking is if you look in the cervical area, we see this kind of like cervical calcification that we see. And, you know, I saw that the restoration has crumbled down, so I decided to go back in and make sure maybe that we haven't lost or that the root canal system hasn't been contaminated with anything, and then try to redo the restoration. So I went back in clinically after I removed this faulty restoration. As we see in the center of this tooth, there's really this was a calcific hard barrier that didn't want to penetrate, and when I just like maybe put my explorer on it, it was a very hard barrier that was there. And I think in this case what happened is that there was a natural cervical dentinal barrier that had formed, that has been promoted by all the procedures that I did. And thus, after what I did in this case, I just redid my permanent restoration and released the patient, and everything after that was pretty good, as we see. So this procedure has been a successful procedure. And as I say, the most, I think, a striking discovery is that formation of this calcific barrier right under the bioceramic root repair material. So in terms of success, when we do this procedure, success is measured by the resolution of the clinical signs of symptoms. Usually this happens in between appointments. The resolution of the periapical radiolucency is also a success factor, and this happens, let's say, around 6 months after the procedure. The root maturation and width takes about at least 12 months to be completed. And finally, the root maturation and length and the apical closure. So in other words, the full maturation of the tooth takes about at least 12 months or more, according to the most recent literature that is out there.
Shafiq, that's a great case, and you did a wonderful job in managing this too. So the patient's symptoms, you said the patient was symptomatic when they returned. Was that from a periodontal area because of the fact that the restoration up on top had broken down, and then there was a maybe a periodontal food? Was that the chief complaint, kind of food impaction?
Yeah, I mean, you know, it was mainly through food impaction, faulty restoration. His gums were a bit swollen because of that. So there was really no endodontic problem with that. In fact, after I had done this, I redone the restoration, I was in touch with the patient and told me with his mother, because he was a young patient. Everything was good and the patient was doing very fine. So just a matter of like a restorative aspect, no endodontic aspect.
So these teeth clearly we're going to follow up, and the indications for them not working would be one that is radiographic purely, as well as patient's own set of, you know, odontogenic symptoms, right?
Of course,
no other tests.
I mean, you know,
obviously the pulp vitality tests and the thermal tests are no longer valid in cases like this.
I mean, you know, yeah, once the procedure is done, if let's say there's no, if the periapical radiolucency becomes bigger, or if it doesn't change in size, becomes smaller, or if the symptoms persist or come back, these are signs of failure of the procedure, which in this case you might tend to retry it, reattempt another try, or maybe try to do some other kind of procedure depending on the case.
Well, I guess once the space has narrowed down enough in such situations, then I guess one could do the complete root canal at that point, and I've seen that done by others as well.
Of course. I mean, no, what you said is 100% right. Once the apical maturation and the root canal has matured to a size that's really manageable with a conventional root canal system, if the symptoms are still there and the patient is still complaining, then we could do a root canal. But if there's no symptoms, we can just keep an eye on it, follow up over time, and then we don't need, as you said at the beginning of the presentation, the best filling of root canal is the pulp or the tissue itself. But of course, in these cases, we don't know what kind of tissue in there. We speculate it's a mix of like pulp-like or cemental-like or PDL-like tissue. But since it's natural, vital tissue, we don't need to intervene as long as the patient has no signs or symptoms.
Yeah, the hard substance in the pulp appears to be the same as the osteoid that we used to get when we used to do apexification procedures. I know we don't do apexifications anymore, but that was pretty much the same idea, except that you were trying to get that barrier at the apex, and now we're trying to get the barrier further up in the coronal pulp, and then have regeneration of the tissue above and beyond it. I think the way I look at it, and I've done a bunch of these procedures myself too, using the putty, and it did work out perfectly fine. As you said yourself, the key here is proper treatment planning and case selection, understanding the principles of success, which is primarily complete disinfection and then release of the natural growth factors that are embedded in the matrix of dentin through through decalcification and so on, and then having a I mean, I have to be honest, I have the ones that I have done, I haven't had a matrix, but Dr. Zimmerman, who's one of our faculty as well, has done some of the original work on using a matrix, and he had wonderful results with them. So I think that's another future pathway as well. One of the other areas is I used to originally use the triple antibiotic paste. The minocycline component of it I found caused staining in the teeth that I had, and so I replaced that with clindamycin for some time and then different antibiotics and so on. But it seems to me that the new trend is to move away from the antibiotic and just go purely with calcium hydroxide therapy. If the goal is just disinfection, the calcium hydroxide should do, and it doesn't cause any staining. What are your thoughts on that?
You're definitely right on that point. A lot of people are complaining about the staining because of minocycline. Some people also use only, let's say, double antibiotic basis. Just remove the minocycline or replace it, in this case, by clindamycin, like you do. And there's a lot of, people saying that in the literature that antibiotic resistance, etc., we should reduce the usage of it. Calcium hydroxide has proven itself to be a great antimicrobial agent. And in fact, literature out there also suggests that calcium hydroxide is much more biocompatible towards stem cells than triple antibiotic paste. It's just that its spectrum of action against bacteria is not as broad as when you use triple antibiotic paste. So you might maybe want to leave it in there a bit longer, or do, let's say, 2 cycles of calcium hydroxide in there to make sure that you're really producing a microbial control that is decent for the rest of the procedure. But this is definitely something that we could attempt, calcium hydroxide.
Yeah, I mean, it seems to be working, and I've done a few of those too, and they seem to work well. In fact, I have a case that I have been following up now for a few years, and I'm soon going to make a little video on with the putty and the revascularization on a tooth that was basically going to be removed. In terms of the viability of this procedure, because everyone now talks about regeneration. Once we're talking about the limitations, meaning having apical opening that is 1.5 millimeters in diameter, that's fairly large size, right? Then it means that in terms of its use as a routine procedure for saving molars and other teeth, Do you find that to be something that at some point we're going to be able to address in terms of its limitations, or do you think the webbing and the anastomoses and the fins that are present in molars are going to be much more difficult to deal with in terms of disinfection, which is the primary criteria for the success of this case, and that this is something that's going to be more uniquely kind of saved and reserved for single-rooted teeth?
Yeah. I mean, definitely with the armamentarium and with the technology that we have today, these procedures are more likely to succeed in single-rooted teeth, just like you said. And something more complicated as a molar, I haven't come across anything in the literature, let's say in terms of case report or case series, saying that it could work or if it worked. I haven't attempted it myself at all, but it would sound to me that we can't lose anything in trying, at least, let's say, in one appointment. If it works, and if not, then we could, let's say, do some epexification with the root repair material or another kind of procedure. But eventually, I think when you're talking about regeneration, which is really the reproduction of the same tissue that's inside the root canal system initially, which is the pulp tissue, I think research is heading there, but we still need some work to do. In this case, when we do this kind of procedure, I tend to more name it as revascularization, because, as we said, the tissue that's that's replaced inside is not really pulp tissue, but some kind of osteo tissue. So we're really in the gray zone right now in all the terminology that we use and what we can do. But in terms of molars per se, I think we're not there yet, but we will be there hopefully very soon.
Yeah. Yeah, I've seen a few of those cases, and sometimes it has to be a very unique case in a very, very young patient, and then you really need to have great disinfection protocol. And I think that idea of making sure that your hypochlorite is at lower concentration so that it doesn't cause any toxicity to the stem cells is a critical thing to get across here. That's something to keep in mind. Well, Dr. Safi, I know you've done many presentations at the various meetings, including this past AAE where in San Francisco, where actually we first had a chat. This was really a great presentation. It was very informative. I look forward to doing more of these videos with you in the future. Thank you so much for joining me today.
Thank you. Thank you for your time. Thank you very much.
I was joined today by Dr. Chafic Safi, Assistant Professor and Lecturer at the University of Pennsylvania and McGill University Postdoctoral Endodontics Program, and the founder and director of Centre Endodontique Saint-Laurent. And for Real World Endo, I'm Ali Nasseh, and I hope you found this information helpful.